start the recording button. So welcome to all of you to the DCAP academic program. And today's the 12th of February, 2021. And we have a really nice presentation by two team members, Stella Mokitimi, who's a mental health nurse with lots of experience across levels of care in the Western Cape province, and Simphiwe Simelane, who's a medical doctor who's trained in the Western Cape and is now doing a PhD with us. And the topic or the theme is child and adolescent mental health services in the Western Cape, current landscape and next steps. And most of the presentation will be Stella's PhD work that she's done. But the main job I want all of you to do as you're listening to Simphiwe and listening to Stella is to think, what do I think are the priorities for CAMHS services in our province? What do I think are the biggest needs from your experience? Because we all work in the Western Cape province and everyone's had some experiences with child and adolescent mental health services and structures. So with that, I'm going to hand straight over to Simphiwe and Stella for their double act. Thank you to both of you.
Hi everyone, I don't know if you can see my screen.
Yep.
You can see it.
And Simphiwe, let me just tell everyone else, we're recording this, so perhaps just mute or take your video away so that we don't record your face. Okay. And that you will remain, not you Simphiwe, but everyone else, and not you Stella, but everyone else. Okay.
Okay.
Great. So with that, Simphiwe, back to you.
Okay. Hello, everyone. As Prof has said, my name is Simphiwe Simelane, and I'll be presenting today with Stella Mokitimi on child and adolescent mental health services in the Western Cape, the current landscape, which is based on Stella's PhD, and the next steps, which will be the basis for the work that I'll be doing. Okay, the slides are just not going forward. Okay, so the story of how I developed a passion for child and adolescent mental health is a personal one. Growing up, I had a younger cousin who struggled with school. Despite trying hard, he would repeat grades until he was promoted without ever grasping the ideas. So no one was ever able to put a name to what was wrong. He wasn't referred or assessed. He was just labeled as a dumb 15-year-old in grade 6, and this continued until he eventually phased out of the system. 15 years later, I sat as a community service doctor at Tonga Hospital in Mpumalanga, with a mom in front of me seeking an answer for her son. He was struggling at school, and after 6 years of medical school and about 5 hours of collective training in child and adolescent mental health, I realized I couldn't put a name to what was wrong. I referred him to the psychologist for an assessment, and after 30 minutes, I got my referral back with a one-liner written ADHD and no evidence of an assessment. So I started him on Ritalin, even though there was no clear record of how we arrived at that diagnosis. This is when I realized that there were some serious shortfalls in the child and adolescent mental health service that we offer at the primary care level. So globally, it's estimated that 10 to 20% of children and adolescents have a treatable mental health disorder. This makes mental illness the greatest burden of disease amongst young people. Sadly, most countries, including South Africa, don't have sufficient data about the prevalence of these conditions. We also know that about half of all mental conditions start by 14 years of age. This means that detection and improvement at this stage is crucial for improving long-term outcomes. So we know that mental illness in childhood and adolescence is common, but that doesn't mean that it's automatically translated into child and adolescent psychiatry being a priority in health services. We need to strengthen child and adolescent mental health systems, but before we do that, we need to understand the current landscape. Stella's PhD focused on this understanding, and I'll now hand over to her to give us insight into her key findings. Stella. I don't know if...
Stella, you are muted. Stella, just unmute yourself.
Yes, sorry.
We don't read lips that well.
Okay, if we happen to have visitors here, we're just showing you where we are and where our services are. As you know, we are all in South Africa, and we're showing the Western Cape province amongst the 9 provinces of South Africa, and where our regional hospitals are, which is Paarl, Worcester, and George. We also highlight here the 3 specialist child and adolescent mental health units in the urban area, the city of Cape Town in the Western Cape. Next, Simphiwe.
Okay.
As Simphiwe said, we have a huge burden of child and adolescent mental health problems, and for that reason, we need to strengthen the services. But for us to be able to do that, we need to gain a better understanding and in-depth knowledge of all the aspects of the service before we can strengthen. So we designed this model that helped us, and we used in the study to understand the aspects of child and adolescent mental health services. As we can see, we look at the policy landscape. We all know that policies are very important. Everything starts with policies, budget allocation, resource allocation, service delivery. It starts with policies. It's also important to look at the resource landscape. What resources are there? What facilities are there? What infrastructure, the human resources, the financing and everything. We need to get a better understanding of what the layout of the resources is like. Also, it is important to look at the senior stakeholders, being the policymakers, the managers, and the planners. That is a top view of the perspectives of those senior stakeholders on how the services are and how the services should look like. It's also important to look at the grassroots level service providers. How do they view the service? How do they experience the service? What are their experiences, and how would they want things to be delivered, and how would they want the services to be delivered? And also to look at our users. How do they experience the service? How do they receive the services? What do they want to be done for them to say, okay, they are getting and receiving very good enough, effective services? So, okay, go back to the previous one. Yes. So today I'm just going to touch mainly on the 3 aspects of the service. I'm not going to do all of them. For those who've listened to the presentation, you'd realize that before I've presented the policy landscape and I've presented the senior stakeholder SWOT analysis. And today I'm just going to do the resource landscape, the grassroots level service provider landscape, as well as the user perspectives. And then I will give overall synthesis of all these aspects of CAMHS and what we found. So let's start with the situational analysis and what we did and what we found. Lucy Gilson, who is a health policy and systems researcher, suggests that health systems, to be effective, in fact, they constitute of software and hardware component, as well as the policy component. The hardware elements being the structure, the organization, technology, and resources. Software talking about the values, the norms, the actors, and the relationships. But we need, for an effective services and a effective health system, these 2 need to be well balanced. And in my study, we actually looked at all these aspects. Next slide. So in the situational analysis, we actually looked at the hardware component. We have said that the hardware and the software is important to understand, but in this section, we looked at the hardware elements of the system, being the human resources, the financing, medicine, technology, organizational structure, service infrastructure, and information system. a good balance, we have said it is important. And so far, up to date, we have not found any fine-grained situational analysis that's ever been conducted in South Africa and in any of the low and middle income countries. So this is the first one. So our main aim here was to examine, as I've mentioned before, the hardware elements of child and adolescent mental health services in the Western Cape. So our study was focusing mainly in the Western Cape province. So we conducted a descriptive situational analysis of CAMHS. We used the World Health Organization Assessment Instrument of Mental Health Systems version 2.2 of 2005. We used the brief version of the tool, selecting 37 items that were of direct relevance to CAMHS, and we also modified those items. We focused on the year 2016, also just collecting data for the Department of Health and the public health sector. We collected our data from the key stakeholders from the Provincial Department of Health. We requested relevant documents and records from the regional office and from individual hospitals and clinical facilities. We also searched from the provincial website as well as Web of Science. We finally did a validation check for any potential or any additional data. That was between January and May of 2020 when we did that. Okay, so we captured all our data and we numbered all our sources of data, and we captured our data using the same WHO AIMS Excel data entry version, and we did a descriptive statistics of variables. This is just to show you how the WHO AIMS adapted to looks like. I'm not going to go through it in details, but I would like you to focus on the domains, and you can also look at the variables in each domain. The instrument constitutes 6 domains. Domain 1, policy and legislative framework. Domain 2, clinical services for children and adolescents with mental health disorders. Third domain, child and adolescent mental health in primary health care. The 4th domain is human resources. 5th one is public education and links with other sectors. And the last domain is monitoring and research. So we collected our data on these 6 domains and exploring the variables that we can see on the right. So this is what we found. In domain 1 of policy and legislative framework, our main findings there was that we found no provincial child and adolescent mental health policy or implementation plans in the Western Cape. We know that in South Africa, we've got the National Child and Adolescent Mental Health policy, and each province is expected to develop its provincially relevant CAMHS policy and implementation plans to give effect to the national policy. But in the Western Cape, we did not find any of that. There were human rights legislation in existence that were relevant to children and adolescents, but again, no financing, no finance, which is allocation dedicated mainly for child and adolescent mental health services. If you see there, the results of the policy landscape, which was a detailed study, are published in the International Journal of Mental Health Systems. That is the paper there, if you want to check for in more details what we find on that paper. But basically, none of the provinces had policy implementation plans for child and adolescent mental health in any of the provinces. In domain 2, focusing on the clinical services, what we found was that there is no regional health authority, mainly for child and adolescent mental health. There is no regional structure in the Western Cape. Even though we do have a regional health authority for mental health, but there is no lead for child and adolescent mental health. Child and adolescent mental health services are organized into catchment areas, or you can say geographic, 5 geographic service areas. Now, when we look at the outpatient services and how they're structured, the outpatient services are offered in all levels of care, level 1, level 2, and level 3, as you can see on the picture on your right. There were, in 2016, there were about 317 facilities that were offering child and adolescent outpatient mental health services at tertiary level of care for about 0.9 young children and adolescents. Okay, and and again, there's 3 tertiary outpatient mental health services for children and adolescents are only available at in the urban areas and nothing in the rural areas. Okay, at secondary level, which is our district hospitals, there were about 34 of those facilities which were offering outpatient services, and only about 7.2% of children and adolescents were seen in 2016 at outpatient, at tertiary, at secondary level. Now, at primary level, about only 273 facilities were offering child and adolescent outpatient services, and only 4.4% of all the patients that were seen in 2016 were children and adolescents. Psychotropic medication was widely available in all facilities at all levels of care for outpatient care. Domain 3. Are we frozen?
No, this is the second part. You missed the second part, Stella. Just go back.
Oh, sorry. Yes, the second part. Oh, yeah, I didn't see where it's second part. Yes, sorry. So let's look at the inpatient services. The inpatient services are offered at 2 levels of care, only the secondary and the tertiary level of care. And yeah, only at secondary and tertiary level of care. And there were about 346 admissions. The tertiary level of care is, again, still only in the city of Cape Town, with nothing in the rural areas. So at secondary level, 42 facilities were offering inpatient services for children and adolescents with mental health problems. However, there were no dedicated beds, again, and no youth-friendly services or facilities for children and adolescents in those inpatient units. Children were under 13 were admitted in inpatient facilities and mixed with in pediatric units. And those were over 13 were mixed with adult mental health patients in adult emergency inpatient units. So about 795 admissions were children and adolescents at inpatient in 2016. We found no other inpatient or specialist residential facilities at that time. Okay. Domain 3, now let's look at the services at primary health care. We found that there was inadequate documentation or training of professionals on child and adolescent mental health services at primary care level. And also that there was lack of dedicated resources at secondary and tertiary care levels to support training to support training for the colleagues at primary level of care, and more so in rural areas. There was also lack of psychosocial intervention at primary care level. Domain 4, human resources. There was no formal data which was available at the time to quantify human resources in child and adolescent mental health versus adult mental health services. And again, there was no disaggregated data between outpatient and inpatient services. We could not quantify the proportions of children and diagnosis and everything. There was also limited resources for child and adolescent mental health at secondary and tertiary care level. For an example, only 8 out of 51 psychiatrists were child and adolescent psychiatrists for a population of over 2 million. Yeah, just too little. Next. The 5th domain, public education and links with other sectors. In 2016, we found that there were no campaigns mainly on child and adolescent mental disorders. The first 1,000 days was the only infant mental health project that was done, which actually has a mental health component. We would know that Prof Astrid was leading the project from our unit. And there were child and adolescent well-being campaign that was also conducted by one of the youth organizations, and an anti-bullying campaign that was done in schools, and 16 days of activism. There was also very limited intersectoral collaboration, especially around child and adolescent mental health. In domain 6, looking at monitoring and research, yes, there was some information that was in existence at the time, but it again was not fit enough for purpose to us to provide disaggregated mental health data for children and adolescents, actually. And there was also no dedicated report for child and adolescent mental health or child and adolescent mental health targets for government monitoring. So CAMHS were again not necessarily featuring in the report. There were 5 active programs that had been conducted at UCT on child and adolescent mental health. So our findings from the situational analysis showed that there are significant gaps in hardware elements of child and adolescent mental health systems. There's limited clinical care provision to potentially fewer than 10% of all children and adolescents, as we have seen, with mental health disorders. And these findings are not a surprise to us. They're actually in keeping with literature showing huge neglect, global neglect of child and adolescent mental health problems. And strategies and initiatives to strengthen child and adolescent mental health services are needed urgently. Let's come now to the perspectives of the service providers at grassroots level. Our aim here in this section was to explore grassroots level service provider perspectives about child and adolescent mental health services, again, only focusing in the Western Cape province. As we have already said, that we cannot say we're going to strengthen the services without understanding the views and incorporating the views of our grassroots level service providers who are directly involved with the service. What we have also noted is that there's been very limited exploration of these views of this grassroots level service. So it's quite interesting now that it's a bottom-up approach, and we actually going to hear what the people who are directly involved in the services are experiencing and saying about the services. As we also know also that services also need to be responsive to the needs of the grassroots level service providers as well. So we conducted a qualitative exploratory study and all our participants signed informed consent. We did purposive sampling, selecting multidisciplinary mental health service providers across the Western Cape who had suitable and in-depth knowledge about the existing challenges of child and adolescent mental health services. We collected our data between May and July of 2017 using focus group discussions and semi-structured individual interviews. We asked them about their lived experiences of child and adolescent mental health services, about referral care pathways, intersectoral collaboration, barriers and facilitators to care, and also requested their recommendations to improve child and adolescent mental health services. All our data, we entered it on our software and Vivo 11, and all the audio files were transcribed verbatim. We conducted thematic analysis, 2 independent researchers, and we also did triangulation. We had 46 participants who were child and adolescent psychiatrists, psychiatric registrars, medical officers, general psychiatrists, and mental health nurses. We conducted 4 focus group discussions and 11 semi-structured individual interviews. And these are the themes that came up from our grassroots level service providers. The theme of lack of resources, number 1, where they show that there's lack of child and adolescent mental health infrastructure, especially at primary and secondary level of care, with again very limited tertiary infrastructure at tertiary level, and non-friendly infrastructure, especially at primary and secondary level of care. Heavy workload, especially for service providers at primary level of care who are hugely overloaded with a caseload of adult mental health cases, and now having to see children and adolescents in their mental health services, which is also time consuming with one mental health service provider in the facility. Lack of financing, which makes it very difficult to allocate resources and infrastructure for children and adolescents. Inequitable distribution of available resources, as we have seen. Most of the tertiary child and adolescent mental health infrastructure and resources are only in the Western Cape, and most of the mental health and specialists are only, in the urban areas, and with nothing in the rural areas. So the limited available resources are only in the urban areas. Lack of intersectoral collaboration, sorry for the spelling there, lack of intersectoral collaboration. The 3 main departments that are working with children, that is social development, education, justice, and health, they work in silos. And oftentimes it puts the service providers complaint that it puts a burden on the Department of Health as they receive inappropriate referrals from the other departments when they cannot manage children. So everything gets referred to the Department of Health, and again, it overloads them. Limited training, inadequately trained service providers, especially again at primary level and secondary level of care. Many service providers felt that we are not competent enough to see children. We don't have the skills, we don't know how to do, and we are not adequately trained. We don't know how to go about. Lack of uniformity and consistency. The 3 specialist child and adolescent mental health units that I showed in earlier slides, which are the only ones in the Western Cape, they are not well coordinated. Each one have got their own specialty, and the service delivery is not uniform amongst these three. Even the referral care pathways are not uniform. So for service providers, it felt like everything, each one is doing their own thing, and often it confuses the service providers as well as the service users, as these three units are working differently. Lack of support for staff. Service providers felt that they are not receiving emotional support and moral support for the challenges that they experience in managing children and adolescents. Some of them, they have to source their own private emotional and moral support. Lack of acknowledgement for staff. Some service providers felt that their efforts, they go unrecognized. They do initiatives in their facilities and they implement those initiatives, and some of them, they feel that they are effective, but there is just no acknowledgement. And often the management seeks to come up with something that is going to work, but they overlook that the clinicians on the ground and the service providers are already doing what they are looking for, and they are not recognized for their efforts. So sometimes they wonder, why does the management look still for something that can work when I am actually doing it in my clinic? Negative staff attitudes. Some felt that some service providers, they just don't have interest in children and adolescents, and they have got a negative attitude, and that prevents them from providing an effective and a responsive service. Sometimes it's just a matter of attitude. If those attitudes can be changed, maybe the services or service providers will be able to provide a better services. Also understanding that there are also other factors that contribute to those negative attitudes. Health service innovations. Innovative service provision by mental health nurses at primary healthcare clinics. There were some primary healthcare facilities that were providing a good enough, responsive and effective services to children and adolescents from those initiatives of these service providers. And that was a positive finding. Despite all the challenges, but there were facilities that were providing dedicated, separate child and adolescent mental health services under the circumstances, and those initiatives were commended. External contributing factors were noted to be stigma, poor socioeconomic circumstances, and substance abuse. These were the recommendations that we received from the grassroots level service providers. They recommended that staff, child and adolescent mental health staffing should be increased. Dedicated child and adolescent mental health services, especially at secondary level of care, and child-friendly infrastructure at primary level of care should be provided. The service focus, which is currently focusing on the statistics, meaning that the number of patients that are seen, that the service providers are pushed to see a certain number of patients per day, is not good enough for effective service and for quality service. So they suggested that that should be reviewed. The focus should rather be on the quality of the service and not on the quantity. Formalized intersectoral collaboration, as we've heard, the three are disintegrated. They need to be formalized at a top level so that all the departments that manage children can work together and not overload just one department. Increase learning opportunities for trainees. Employ a lead professional for child and adolescent mental health in the province. As we heard, we do not have a lead. And this lead, they actually said this lead is the one who would be able to coordinate child and adolescent mental health in the Western Cape, and also coordinate the 3 specialist units in the Western Cape so that they can work uniformly and consistently. Increase support for staff, emotional support and moral support, and staff initiatives need to be acknowledged. This section of the study showed that there were definitely challenges and gaps, both in hardware and software elements, lack of structure, coordination and governance and leadership, unresponsive services to the requirements of the grassroots level service providers. This study also pointed us to the solutions to strengthen CAMHS as we've heard from the recommendations.
Stella, I'm sorry to butt in. You need to go quickly now,
okay.
So that Simphiwe has time and so that we have some discussion time. Okay. If you can wrap up in the next maybe 3 or 4 minutes, please.
Okay, let's touch on the third part now, the perspectives of the service users. In South Africa, we'll know that we've got the Batupile principles, which actually emphasize that people should be put at the center of the service. The services should be people-centered, but we're not sure in child and adolescent mental health services if these principles are well executed. We conducted again a qualitative exploratory study, and all participants signed consent forms. We did purposive sampling, selecting users who could be able to engage, emotionally stable and not psychotic at the time, and were receiving treatment. Were children and adolescents from 12 to 18 years of age. We collected our data again between May and July using focus group discussions and semi-structured individual interviews.
Stella, I would suggest just jump straight to the results.
Okay.
Otherwise, this is exactly the same method. It's for the,
it's the same, yes. The method section here is exactly the same as the service providers. Okay, so here we had 22 participants, as we see, 10 caregivers and 12 adolescents. Over. Okay, let's get to the main themes. And what we found here: slow, inappropriate and unacceptable child and adolescent mental health services at primary level of care. Mainly the service users here complained about long processes and waiting times. Sometimes the folders are missing. Sometimes they are getting too frequent appointments and children miss out at school. Sometimes they are given wrong dates for appointments. There's lack of priority for children and adolescents. They stay in the facility the whole day. The other one is lack of dedicated child and adolescent mental health resources at primary and secondary level of care. Lack of dedicated child and adolescent mental health infrastructure, as we've seen at primary and secondary level of care. Exposure to contagious medical conditions, especially for the children who are mixed with pediatric units with medical conditions. Traumatic exposure to adult psychotic patients at primary and secondary care, where children are mixed with adult mental health patients. Lack of equipment, as we've said, no beds for children, no child-friendly equipment. Lack of privacy and confidentiality, especially in the manner in which consultation is done at primary level of care. Staff rudeness and negative attitudes. Some are being shouted at and screamed at by the staff, and in some facilities they are denied and refused services when they are and they are turned back to the mental health section. A positive new service structure, well organized at a primary outpatient clinic. This was a very positive finding. And if we remember earlier on in the service provider section, there was staff innovations, a well-responsive clinic. And now we hear from the users commending what we've heard from the service. So they acknowledged very much the initiatives and the innovations of the service providers, and that the services were separate and were responsive at primary level. Well-organized tertiary outpatient clinics were commended by the users, being faster and well-coordinated CAMHS clinics at tertiary level. These are the recommendations that our service users came up with. Restructure processes and procedures to become more child-friendly. They cried out for that. Create separate child and adolescent mental health services, please. Prioritize child and adolescent mental health services and provide equitable services. Provide clear communication and information, including formal psychoeducation to our caregivers. And again, these themes show that the current services are not at all in keeping with the Batupele principles. Child and adolescent mental health services are experienced as being poor, unacceptable, and actually without respect for users. These experiences of poor services, it actually acts as a barrier to future care. Responsive and person-centered services were recognized as we have heard and appreciated by the users. And the recommendations that are provided here, they provide important evidence to guide strengthening of child and adolescent mental health services. Overall synthesis, this is all the aspects. I'm not going to name them. As you can see, these are all the aspects that we explored in our study. Go down. Overall, our study showed challenges both in hardware and software elements, lack of structure, coordination and governance and leadership, limited clinical care provision to potentially fewer than 10%, very unresponsive services to the requirements of service providers and users. These findings also identified a potential to use the local expertise and innovations of mental health care staff. The strategies and initiatives to strengthen CAMHS are definitely needed, and they are needed urgently. We plead that the voices of users should be incorporated into policy development and implementation and in service strengthening. Overall, in all these 5 aspects that we explored, these were the overall recommendations. Number 1, employ a provincial child and adolescent mental health lead. 2, formalize intersectoral collaboration, make child and adolescent services more efficient, increase child and adolescent mental health staffing, increase training for trainees, increase support for staff. So our next step is to share our findings with multi-stakeholders, and this is one of the platforms as we are doing this, also to generate joined up plans to strengthen child and adolescent mental health services. Okay, and we hope that data collection could not only be limited to the Western Cape, but the same study can be done at a national and level. There is urgency for national and provincial government to actually recognize child and adolescent mental health as a priority. Okay, this is where I hand over to Simphiwe.
Thank you, Stella. I'm going to try and be as quick as possible. Okay, so after sharing findings and recommendations with stakeholders, it's going to be important to engage the stakeholders on what areas need to be initial priorities while we try to strengthen the system, as each stakeholder brings a unique perspective based on where they fit into the system. So generating those shared priorities and action plans ensures that everyone's on the same page and buy-in from the stakeholders during implementation. Okay. So child and adolescent mental health conditions, as we know, are diagnosable and treatable using evidence-based practices. And the advantage that the Western Cape has over the rest of the country is that it has access to all members of a multidisciplinary team, even though they aren't evenly distributed across different levels of care and geographical areas. There's good infrastructure in general for the division of levels of care, even though the infrastructure is not translating to good infrastructure for CAMHS. And then there's also access to medication across all the levels of care. So we need to find a way to organize the system in a way that leverages these strengths. And from Stella's PhD findings, we can see that the primary and secondary levels of care could be the initial areas of focus, but all levels of care and stakeholders need to be involved. And it's important it's important that any changes that take place are systematic, and the ultimate goal is informing policy that's going to be drawn up and accepted, implemented, and easily adapted across the very different South African settings that we have in different provinces. So it's a big task, but as the saying goes, how do you eat an elephant? One bite at a time. So there are strategic ways that we can approach this mammoth task. Okay, one way of approaching it is by following the principles of dissemination and implementation science. I've put the definitions there, but I'm just gonna say my little interpretation of them. So implementation research will allow us to integrate evidence-based practices into our clinical settings in a way that's really usable, because just showing that something works through research doesn't necessarily mean that it translates into our practices. And then dissemination research allows us to spread the knowledge, because we know that journal articles and guidelines often don't reach the audiences that they were intended to reach. Okay, so I'll be focusing on how we can use implementation science to strengthen the health system. Okay, so we know that evidence-based practices, that there are evidence-based practices, ways of evaluating and managing our patients, which have been shown to be effective. And this simple implementation framework by Proctor et al. Shows how implementation research can be used as a roadmap of how we can get these to be used in a way that is effective and well coordinated and adapted for our setting. So examples of implementation strategies are shown here. Examples of implementation strategies are shown here. And last week we heard from Matt, who would be focusing on the group learning or the training aspect. The outcomes of implementation research, the outcomes of implementation research are, they're numerous. So one of them is implementation outcomes, and that focuses on the implementation itself and how well it was implemented. And then there are service outcomes, which might be a main area of focus for policymakers or for managers and at the facilities in which the implementation takes place. And then also from Stella, what Stella said, we see that the actual users do take note of service outcomes as well and how well the service is provided to them. And then there are client outcomes, which are likely to be the main area of focus for service providers and users. So I'll be using the collaborative care model as an example of how an implementation strategy can be used to reorganize the primary care system and improve supervision at the primary care level. So the collaborative care model is made up of 4 components: team-driven care, population-focused care, measurement-guided care, and evidence-based care. Okay, so the core team in the collaborative care model is the mental health nurse practitioner or a nurse practitioner in those areas that don't have mental health nurse practitioners, a primary care physician or the medical officer that's at the clinic, the psychiatrist, and other team members may include admin staff, pharmacy, management, and other health professionals, depending on their availability at those levels of care, and then also social workers. It sounds very similar to the kind of team that we already have at the clinic level, but the model delivers the care in a way that's coordinated, as opposed to the way that we are sort of doing it facility to facility, depending on what the team decides. It uses measurement-based outcomes to guide management, which makes it clear who's improving and who's not improving, and then also has routine scheduled caseload reviews with the psychiatrist, so that rather than consultation as needed, which leads to sometimes making calls when someone is not available, confusion about who to call for advice. And this team approach also allows for case-based training rather than lectures and seminars, which is a more effective learning tool for adults. So for the trainees or for the primary care providers, it would allow for them to learn on a case-based system. Okay, so linking back to Stella's presentation, this actually addresses 3 things. So it addresses the efficiency of the of the mental health services, and then increases support for the staff at the primary care level, and then it would also increase the training for the trainees. Okay, it's population focused, and one of the problems that we identified, or that Stella identified, is to do with information systems and the recording of child and adolescent mental health stats. So it makes it difficult when decisions about resource allocation are made. So population-based care means that the primary care provider would keep a registry of the patients, the child and adolescent mental health patients which they are seeing. And that helps for improving health outcomes for that population of patients. And then also allows, because the patient scores would be on that registry, it allows for identifying which patients need more attention. So it would allow for quick access to that information and seeing who needs to be prioritized when discussing with the consultant. And then also it allows for segregated data. So one of the main problems now is that the child and adolescent mental health statistics or data are mixed in with everything else. They're mixed in with adult mental health services, and they're mixed in with general services. So this would allow for a segregation of the statistics so that we can see what's going on specifically in child and adolescent mental health. And it also improves the capacity of the conditions that can be managed at mental care, at primary care level. So it allows for knowing that the consultant will be reviewing the cases, means that more complicated things can be managed at lower levels of care. Okay, so that, so I've grayed out employer provincial head, because hopefully better statistics and seeing the need will allow for motivation for employing a provincial head, which we don't have right now, but it does make, again, the services more efficient, and it increases staffing. And it may lead to an increase in staffing as well, again, because we can motivate using the statistics. Sorry, Prof, I just want to know, should I maybe stop and skip to the last slide or continue? I can and just see the time.
Yeah, no, maybe if you could do like a wrap up in a minute or two. Sorry to do that to you.
No problem.
This is your exercise in flexible presentation.
Okay, I think I'll just skip to the last, yeah, okay, I'll wrap up. So in terms of measurement guided care, the collaborative care model would allow us to treat to target. So it would use symptom rating scales to identify the children, and then be able to guide them to the right referral pathway, and then also use them to check for improvement, which prevents being treated in the same way with no response. It allows everyone to speak the same language. It actually empowers the patients and the parents as well, because they would understand how the child is improving, what to look out for, and have a better understanding and grasp for the children's conditions. And yeah, just allows the primary care providers and the psychiatrists to be speaking the same language in terms of improvement. So again, it increases the support for staff, because they know exactly what they're looking for and how to look for improvement, increases the training, like I've said before, and then it makes services more efficient. Okay, evidence-based care, and this allows, we know that there are effective, like I said, effective treatment that we can use for child and adolescent mental health services, and this would allow us to adapt them to our setting. Okay. So again, making the services more efficient. Okay, so lastly, how do we take that first bite? We need to identify priority areas with the stakeholders, and Stella will have done a lot of the work on identifying who the stakeholders are, so we didn't have to reinvent the wheel in that sense. Using implementation science as a tool to make changes, not only in research, but using the same tools in practice to implement new strategies, and then embedding dissemination into implementation, research, and practice from the beginning. So not thinking about how we can disseminate the information as an afterthought after we've already established that it's successful, but including the policymakers from the beginning and having a plan on how rollout rollout will happen afterwards. And then effecting change at different levels in a way that complements each other. So not an initiative happening at primary care, initiative happening at tertiary care, and everyone doing it in an uncoordinated fashion, but working together and having transparency and ongoing communication with how that will be done at different levels. And I'd like to acknowledge all of these groups and people. Okay. Now we can hand over for questions in the last minute.
I'd like to just stop sharing your screen.
Okay.
And I'm very sorry, I can see lots of people having to run. So let's first do a quick round of applause to Stella and Simphiwe. And I am keen, in the last minute or two, I've asked you all just to type in what you see as priority areas for us. But if there's anyone who heard something that you say, yes, I think that's really important. Yes, that's really what we should start with, because there are so many things that can be done. So let me see if anyone wants to make a comment.
Petrus, I'm going to stop recording if that's good for you.
Oh,